All right. Hello, IRI fellows. My name is Andrew Quanbeck. I'm an assistant professor in the Department of Family Medicine and Community Health at the University of Wisconsin-Madison. I'm a past IRI fellow, or I guess once an IRI fellow, always an IRI fellow. And I'm thrilled to be invited back to share some of my research with you. You can go ahead and advance the slide. So I just wanted to acknowledge some of the funding that made this possible. I'm going to tell you about sort of a two-phase research process. We did an R34 clinical trial planning grant and then an R01, both funded by NIDA, worked with UW Health Primary Care Clinics in the Madison, Wisconsin area, and want to acknowledge members of the research team who contributed to all of this work. Next slide. So the research that I'll be talking about has a long trajectory, as I mentioned. Our first R34 grant submission we put in February 2013, and have been working on this project more or less continuously since then. If you're not familiar with the R34 grant mechanism, it's there to help test the feasibility, acceptability, and preliminary effectiveness of novel implementation strategies, or at least that's one way it can be used. We submitted in February 2013, resubmitted at our first opportunity, and started our R34 in July 2014. And I'm going to kind of walk through the whole trajectory and to where we are today. Next slide. So this chart illustrates the steady rise in the number of opioids dispensed in the United States between 1991 and 2011. Well, actually, it goes past that. This is a little bit outdated, but the total amount of opioids prescribed reached an apex in 2011 and started to level off and move in the other direction, and that trend has largely continued. Next slide. So even though prescribing rates have slowed down, overdose death rates have continued rising. And actually this, I haven't updated this slide recently, but death rates started to decline a little bit in 2018 before heading back up in 2019, and unfortunately are back at record highs in 2020, and I think a lot of that could have to do with the COVID-19 pandemic. But certainly, this opioid has been a huge societal problem that's been building for a really long time, and it's sort of like in a crash phase. And unfortunately, I'm afraid we have quite a long way to go to ride this wave out. Next slide. So this chart is especially relevant to the research I'll tell you about. It shows the increased risk of overdose as a function of morphine equivalent daily dose prescribed to patients. So dose reduction has been and continues to be a key theme of our project. There's talk in the implementation science world about the need to de-implement ineffective or harmful practices, and looked at it a certain way, prescription opioids really require one of the largest de-implementation efforts that we've ever seen in the U.S. healthcare system. Next slide. So I did want to point out, this is an article from 1980. Was been cited, at least earlier this year, had been cited more than 1,000 times. And this article formed the basis of a lot of the rationale to liberalize opioid prescribing practices throughout the 90s and the early 2000s. So I'm not sure how many of you have actually read this study, but if you haven't, we can do it pretty quickly. Next slide, please. because that citation, which had such an effect on the healthcare system, cited more than 1,000 times. This is it. This is not the abstract. It's the entire scientific work. It's a single letter to the editor in the New England Journal of Medicine from 1980. I'll give you a minute to look at it. As you can see, it's not exactly what would constitute a very rigorously designed and ironclad case for an evidence-based practice that should be widely adopted. So anyway, this letter to the editor had a really large effect, and we've kind of been trying to undo it for the last, I don't know, 8 or 9 years at this point. Next slide. So, you know, we kind of think about this as a de-adoption project, but it's hard to replace something that exists with nothing. So one of the first things that we had to do in our R34 clinical trial planning phase is determine exactly what we would implement. And we selected the guidelines written by Roger Chow and colleagues that were published in the Journal of Pain originally in 2009 as a basis. A version of this guideline later became the basis for the CDC guidelines for opioid prescribing that came out in 2016. Opioid management, it's always been a controversial issue, but there seems to be consensus that's emerged about a few basic ideas. Probably first and foremost is that high doses should be avoided, and a threshold has emerged for better, for worse, around 90 morphine equivalent daily dose. That is informed by some prior research, so it's at least has a decent evidence base. There also, you know, clinically, there needs to be frequent follow-up screening and monitoring of patients, and a lot more communication around the risks and benefits of opioid therapy. Next slide. So the clinical guideline that was originally put out there in 2009 had all the information you would ever need around opioid prescribing, but it's not presented in a very digestible format for primary care physicians who, you know, notoriously are really hard pressed for time constantly. So the guideline is a 40-page journal article. It has 25 recommendations in it. It's really a lot for anyone to take in, let alone for a busy primary care physician to actually act upon. So our goal was to compress and prioritize the guidelines using a systematic process. Next slide. We were able to recruit three of the 5 leading authors of the clinical guidelines to participate in something called the integrated group process, including the lead author, Roger Chow. We teamed the guideline writers with 3 primary care physicians, 2 systems engineers and implementation specialists, and a national leader in drug policy. And we put this multidisciplinary group to work on something called the integrated group process. I'm not going to go through all the steps. You can read about it in this Gustafson 1993 citation. But the goal is to kind of systematically go through a series of steps, and with the aim of producing a succinct checklist that prioritizes the recommendations and shapes them into a step-by-step process for implementation in clinical settings. Next slide. So this is the checklist that we ended up producing by applying the integrated group process. Remember, we started out with 25 recommendations, and we got it down to the 8 kind of top recommendations from the guidelines. We chose that number intentionally. There's a rule of thumb that goes way back to research in the 1950s, an article called the magic number 7 plus or minus 2. And that basically, that rule of thumb says that human brains really can't process more than around 7 7 pieces of information. Anything beyond that just leads to information overload. So magic number 7 plus or minus 2 is the information processing channel capacity that you're dealing with when working with human beings and health systems. So we, among these 8 elements, we encourage clinics to just pick one element to start on, kind of work at things one thing at a time. It can be overwhelming to try to do 8 things, so we don't want people to get discouraged, but just to pick something and get started. Next slide. So again, here we were designing an implementation strategy to pilot test. It was based on a quality improvement model named NIATEX that had been widely adopted in the addiction treatment industry. If you want to read more about NIATEX, I'm not going to go into a lot of detail, but this article provides a good summary. So when we were writing the R34, we thought that NIATEX model showed a lot of promise for opioid prescribing and primary care, but we knew that some translation and adaptation would need to be made for the model to work on a new problem in a new setting. One of the things that we had learned in our studies of the NIATEX model in addiction treatment is that peer coaching was the most cost-effective implementation strategy to disseminate the NIATEX model. So from the beginning, we built upon that empirical finding and decided that coaching was going to be a centerpiece of our implementation strategy. Next slide. So we worked with 4 clinics in our pilot test, and we had 2 physician peer coaches. Both of them are MD faculty physicians in the University of Wisconsin Department of Family Medicine. We selected MDs because they have hands-on experience with opioid prescribing, and so they've dealt with difficult issues around opioids firsthand with their patients. We felt it was really essential to the coaching model that the change agents that we're asking to go and talk to clinics were MDs themselves, since we're trying to influence practice at the level of prescribing, which is really an MD function. We had to match up the coaches and or maybe looking at the Proctor framework, the actors and the action targets, and make sure that they had a degree of homophily, which, if you remember from diffusions of innovation theory, is the degree of similarity between change agents and the individuals that they're trying to influence. Next slide. So we had clinics focus on the prescription refill process. Every clinic has a system for doing refills, and there's refill requests coming in on a daily basis. So it provided a way, there's a place to start for any clinic on any given day. You know, that we had a lot of kind of back and forth about the approach that we should take. And, you know, there's some that might say that our goal should be just to not prescribe any opioids for chronic pain, but that's a really hard thing to do in an implementation project for a couple of reasons. And this is, you know, coming from physician colleagues of mine. I'm an engineer, not a physician, so I'm just speaking secondhand here. But we know that you can't cut patients off of opioids cold turkey. There can be serious withdrawal effects. So patients need to be tapered off opioids very slowly if we're going to seek dose reduction. You also never know when the next patient with chronic pain might show up at a clinic, so it's inherently unpredictable, and it's hard to plan a project around the initiation of new patients. And finally, we think that more judicious initiation of new prescriptions is certainly a goal that pretty much everyone in the medical community shares at this point. But we have a pretty large problem on our hands already. And so the idea here is to start building a system for handling opioid prescribing in primary care clinics. The very act of building a system and the thought and effort that's involved in building a system is likely to force lasting behavior change around opioid prescribing. I don't think you can just tell somebody to do something or to stop doing something and expect anything to happen. You have to instead start doing something concrete, and that's kind of the basis of our implementation philosophy. Next slide. So on to the details of the pilot study itself. We recruited 4 intervention clinics and matched them with 4 control clinics in a randomized match pairs design. Each clinic team or each physician coach worked with clinics on implementing the guidelines over a 6-month period. We had 3 in-person site visits and 3 follow-up telephone and video conferences. We had a series of quantitative outcomes that were analyzed using difference in differences analysis, as well as mixed methods, qualitative techniques that included ethnographic field techniques, focus groups, and interviews. Next slide. So as far as, oh, there we go, feasibility. We had 13 clinics as our recruitment pool, and we randomly approached clinics one at a time. We had to approach 7 clinics to recruit for. The 3 that declined cited lack of time or leadership turnover as the reason for not participating. Baseline prescribing rates for long-term opioid therapy were fairly low, 1.4 versus 1.2% in the clinics, low and pretty comparable. Each clinic had a project team of around 6 to 8 staff members. We wanted to make sure that they had at least 1 primary care physician, and then kind of a mix of other important roles in primary care clinics, RNs, MAs, and administrators. We laid out our intervention or implementation strategy. All 4 clinics completed the implementation period, and our attendance among the teams at intervention meetings was 83%. So we thought that generally we demonstrated some feasibility. Next slide. Effectiveness. So this is probably the main finding from the pilot study. If you kind of turn this into percentage terms, the intervention clinics reduced their prescribing by around, I think it was 11%. Control clinics went up by about 9%. There's about a 20% difference in the change in prescribing rates over the course of the study, which was a statistically significant finding. So our main aim of reducing opioid dose seemed to have some indication of preliminary effectiveness. Next slide. This is the percentage of consistent and long-term opioid therapy users with mental health screening by intervention month. You see that a separation started to occur after a couple of months of intervention between the intervention and control clinics. Next slide. Treatment agreements. So there's been a push for patients who are on long-term opioid therapy to really kind of sit down with their primary care physician and talk through the risks and benefits of long-term opioid therapy. And we saw a trend towards greater initiation of treatment agreements in the intervention versus control clinics. Next slide. And similarly, urine drug screening, periodic, at least on an annual basis, is recommended by the guidelines, and we saw at least a trend towards greater rates of urine drug screening among the intervention clinics. Next slide. All right, so we had a set of effectiveness outcomes and saw kind of a mix of pretty strong effectiveness, at least in our primary outcome, and some indications of effectiveness in some of the secondary outcomes. Staff, we did qualitative interviews and surveys, and staff seemed to respond. they voted with their feet by showing up to 83% of the meetings, which was one good indication. And they also did feel like they became more familiar with guidelines for safe opioid prescribing, and felt like their workflows for opioid prescribing got easier. And we did, clinics really did seem to appreciate the kind of support we were providing. They're sort of used to getting policies handed down from the health system level without any kind of implementation support. So it was appreciated that we had, a physician-led team coming in and trying to study workflows and aid clinics implementing guidelines around this tough issue. So that's one of those, I've been part of projects where I think the clinics teams can't wait to beat the researchers out the door, but that actually wasn't the case in this project, which is always a good sign. Next slide. We had to make some adaptations to our approach. We originally planned on like half-day site visits. We were able to fit all of our meetings in over the lunch hour, and provided food, which was also something that helped encourage attendance. So kind of fitting the implementation strategy to the audience and their constraints. And we sort of learned through our workflow analysis about how other chronic conditions are treated in primary care, especially hypertension and diabetes, and kind of turning chronic pain into another, using some models of monitoring and reach out and follow up that resembled what clinics were doing around these other chronic diseases. Next slide. So again, it was an R34, not designed to be a fully powered randomized clinical trial. Only 4 clinics, 28 staff members, and about 500 patients in one health system. We did kind of the best we could with the study design for the number of clinics we had, and you can kind of see in some of the charts that I showed that things had begun changing already with the introduction of the CDC guidelines and policies, so that even though we saw greater improvements in the intervention clinics, there certainly was some movement in the control clinics as well. Next slide. And if you want to read more about the pilot phase of the research, we had the results published in Implementation Science in 2018. Next slide. So kind of switching gears into the next phase of the research. We were lucky to have the results published in January of 2018, and we submitted our R01 for the February 5th, 2018 R01 deadline to the DIRH study section. Our application scored very well and was funded on the first try. I think that having the R34 pilot data really bolstered our application, and we received funding and started on October 1st in 2018. We're in sort of a weird state at this point because we started clinic recruitment and began the intervention of February 2020. And then of course, in March, the whole COVID situation hit. So we had to pause recruitment and pause the study. We're basically back at a point now where we're finishing the recruitment process and getting the study relaunched. We're actually doing our first stage randomization on September 13th, and I'm taping this on September 11th, or September 14th. Anyway, we're reaching a very important phase of the research. Next slide. So I wanted to just kind of talk, and I think this is really what the IRI leadership wanted me to talk about, is how we conceptualize what an R01 study design would look like based on what we learned in our pilot. And there's a couple, one one thing that we certainly could have done and might have been the easiest thing to do on some level would be to just have a simple intervention versus control 2-arm cluster randomized trial. We considered a stepped wedge design in which all clinics receive the entire systems consultation implementation strategy approach without adaptation. And a lot of people are using stepped wedge these days. However, in our pilot research, we really saw that adopting a more is better approach can be needlessly costly and potentially even counterproductive if we're offering support that's not seen as helpful. So the study, we ended up selecting a sequential multiple assignment randomized trial design. And our study as currently designed really allows us to pose a lot of important scientific questions, and we're hoping that the results will help, and the study design and its results will help advance the field by providing some empirical evidence that researchers can use to tailor implementation strategies. Next slide. So I just mentioned the SMART trial. The way this happened in real life, and we had just finished our pilot phase of the research, and I went to the CERT conference in 2016 in Seattle, and I watched a workshop led by Danny Almarell, and heard him talk about the sequential multiple assignment randomized trial design, and a lot of bells and whistles started going off in my brain that this could really be the way to think about designing our R01 follow-up to the pilot study. For those who don't know Danny, he's an incredibly dynamic and brilliant statistician, and it's been really a lot of fun to work with him. I reached out to him, and we co-designed the study together, which was a real gift to be able to talk through things with him. Next slide. So I'm going to talk about some of the advantages from my perspective of using the sequential multiple assignment randomized trial design. And hopefully, I'll go over some of the highlights, and you all can read the paper that describes the protocol. But these designs allow you to determine the incremental costs of one intervention or implementation strategy over another. They're kind of designed to do that. You can determine added value of implementation strategies. They're kind of pragmatic by their very nature. And, we're ultimately, I'm an engineer, and so cost effectiveness is something that really drives a lot of my thinking around practicality in implementation research. I think if we can't say something about costs and cost effectiveness, then we're really not doing all that we can to learn about the long-term sustainability and practicality of using these strategies in the real world. Next slide. So I'm going to say a little bit more about SMARTs in a minute, but this is something that in our preparing for the R1 application, we did a literature, or we actually didn't do our own literature review, but we found a literature review from 2015 that examined 91 studies that looked at implementation strategies or implementation of interventions in primary care settings. And one of the things that was evident is that that most implementation strategies are not targeted at the health system level. They tend to focus on individual prescribers or providers. Virtually none of the studies out there looked at cost or cost effectiveness. There's not a lot of guidance about which strategies are ideal to be used under what conditions. And again, as I mentioned, more of a systems level kind of approach would really be helpful in learning how to target implementation strategies at different levels. So, so as I mentioned, you know, I had attended a workshop led by Danny Elmerill, and I started thinking about some of the things that we observed during the pilot stage that really made me think that a smart design could work. First of all, not all clinics require a kitchen sink approach. And this was especially evident at one clinic where I attended all the site visits, and we went to this clinic, and we had our physician peer coach lead a meeting. This was intended to be more of a recruitment meeting about what the study was going to be about before we started the active intervention. And the physician peer coach from our research team got into a side conversation with the medical director of the clinic, and you could tell that they were really in sync. And basically and they agreed to participate. We came back the next month to start the intervention, and we found out from the medical director that he had already gone ahead and basically implemented every element of the guideline with all of his chronic pain patients over the past month. So in this case, simply hearing from a respected physician on the faculty of the university seemed to be enough to affect change, and that's all we needed to do. We kept coming back for 6 months after that, and I think we could feel some level of frustration because it's like, we've already done everything that you want us to do. Why do you keep coming back here? So that was a pretty clear indication that, you know, we potentially don't need to provide a full-on implementation strategy without adaptation to all clinics. We basically, I'm not going to go through all these observations, but just a couple. We developed a team-based engagement model where we really originally intended for the physician expert consultant to really lead the show, but it morphed into something more like a team coaching model, which sort of mirrored the structure of primary care work teams and primary care clinics. So we had a facilitator, master's level trained facilitator who did a lot of the communication and outreach with clinics. Our physician peer coach, you know, played a leadership role, but you know, we distributed a lot of the work so that some of the communication was handled at different levels that were kind of matched the way that primary care clinics are structured. We realized that we needed to build in a performance tracking system so that basically the teams could keep track of what they were doing. And that's something that we, you know, based on feedback, built in audit, what we call them audit and feedback reports in our follow-up study, performance reports, just so that there could be some monitoring of progress. Next slide. We definitely saw that different clinics prioritize different focal problems, and that led us to believe that different problems may lend themselves more readily to different types of implementation strategies. So for instance, if a clinic really wanted to focus on urine drug screening, which at least one did, then workflow assessment using facilitation might be the most effective and certainly the most cost-effective way to deliver that kind of support, because a lot of those are sort of administrative processes. They're not handled by MDs. However, if a clinic wanted to focus on opioid benzodiazepine co-prescribing, which some other clinics did, then really physician peer coaching is what's going to be needed, because that's a prescriber level kind of interaction and really complex decision making. So that those different problems require different approaches. As the intervention drills deeper, all the way down to the kind of patient prescriber level, we felt that we needed, and for issues like opioid benzodiazepine co-prescribing, we knew that we were going to need a very intensive kind of one-on-one prescriber peer consulting model. And finally, we saw some different determinants of effectiveness of the different strategies across a multitude of different levels. Next slide. So the specific aims of our follow-up R01, we designed an adaptive systems consultation implementation strategy and compared it to sort of a system level approach, and our primary outcome is morphine equivalent daily dose. We developed an assessment of contextual factors that we thought might influence the effectiveness of different implementation strategies, kind of based on what we observed in our pilot test. And then we're going to be estimating the costs and effects of delivering 4 different sequences and combinations of strategies, including incremental cost effectiveness. Next slide. So we're using a multi-level implementation strategy framework. This is another one of the readings that I suggested everybody take a look at, especially for this topic of policy level kind of implementation research. I think a multi-level framework is really important, and it's something that I've basically built into all of my research studies. So this one is from Furley and Shortell. It's a multi-level system framework for organizational change. Kind of looks at things at the health system level, clinic, prescriber, and all the way down to the patient level. And we matched implementation strategies at each level. So educational meetings are system level. They're directed at the system level, and that's how we start out our intervention. We then move into practice facilitation, which is a clinic level strategy focused on clinic processes and workflows. It allows for a bit more tailoring, but it is more labor intensive than just providing kind of a broad-based educational outreach. And then we move into physician peer coaching, which, as I mentioned, is really focuses on the management of challenging patients, and it's a physician to physician kind of model. Obviously, it's drilling deeper, it's getting more tailored, but also more resource intensive as we get closer to the prescriber patient kind of interaction level. Next slide. So this is the study design, which is also in the paper. As I mentioned, we start out at baseline by providing system level educational meetings to all the clinics who enrolled in the study. In those educational meetings, we're introducing system level audit and feedback reports, so that each clinic and prescriber can monitor their progress on some of the key guideline concordance measures. We then randomize where half the clinics receive practice facilitation in addition to the educational meetings. We run practice facilitation for 6 months. Then we have a second stage randomization to either receive prescriber or peer consulting or not. So, and that intervention lasts for 12 months. So all in all, we have a 21-month implementation strategy, and we have 4 different combinations of strategies that could be received by the clinics who are participating. Next slide. We're working with both family medicine and general internal medicine clinics in 2 health systems. Again, UW Health was the site of our pilot research, and we are now expanding system-wide. We're also working with an organization named Bellin Health, which operates in the Green Bay, Wisconsin metropolitan area. Our goal is to recruit 256 prescribers. We're currently very close to reaching that goal. I think we have like 33 clinics and 240 some odd prescribers, so we're closing in on our recruitment goal at this point. Next slide. For our outcomes assessment, this is something which I think is a neat feature of our study. Again, we use electronic health record data for our pilot evaluation, and we built specifications for generating opioid metrics based on that pilot experience. And we're now working with kind of a data broker organization called the Wisconsin Collaborative for Healthcare Quality, who gets electronic health record data from most of the large health systems in the state of Wisconsin, including UW Health and Bellin. And we've been working with them to generate these metrics and kind of harmonize and synchronizing them across both of the health systems. So that's been a fairly intensive process, but they've done good work on other studies, and things are coming along well. The outcomes there are based on the REAIM framework. I won't read through them. They're also in the paper that you can refer to. Next slide. So this is another feature of our study. We're doing a tailoring assessment. Our goal is to develop a tool that decision makers could use to predict which implementation strategies would be most effective in different settings. We're going to be doing assessments at 4 different time points, and then doing a post hoc analysis to determine if we can identify patterns indicating whether different strategies work better for different types of clinics and focal problems. I mentioned that we have hunches that that's the case, but we're actually going to be testing it directly in this larger study. We're testing 4 moderators and other factors that affect implementation. So kind of the existence and degree of adherence to a system-level opioid prescribing policy, an assessment of clinic-level experience and quality improvement, a size of the clinic based on patient count, and then the prevalence of high-dose opioid patients defined as those who are over 90 MME. Next slide. And then another, hallmark or key feature of what we're doing is cost effectiveness analysis, which, we don't see all that often, and frankly, I don't think see often enough in implementation research. So we're going to be analyzing, we did some pilot cost analysis in our R34 study. So we have kind of the mechanisms in place to measure costs. And we'll be doing that for these 4 different sequences to help decision makers weigh the costs and effects of using different types of strategies. We're using an engineering economic approach. So rather than taking the societal perspective, which is sort of most common in cost effectiveness analysis, we're using the perspective of organizational leaders who ultimately make decisions about adopting evidence-based practices in organizations. They also, set policy and implement policy. So that's, I think, the type of decision maker that we want to be thinking about when we're doing cost effectiveness analysis for a study like this. And then we're using incremental cost effectiveness ratios to quantify the trade-off between costs and effects by scaling up the implementation strategies for both the primary and then a set of secondary outcomes. Next slide. All right, so kind of bringing it all together here. We've known for a long time that opioids is a huge problem to deal with, and now we need to figure out what to actually do about it. after working with physicians on the front lines for a few years now, it's really clear to me that this is going to take a long-term and sustained effort. And, it's multifaceted, and we're just trying to kind of address one element of the problem with this project. I don't think that we or any of us can afford to take any really hard line stances on opioids one way or the other. I think anyone who would view the problem or the whole issue in black and white terms doesn't really understand the complexity of the problem. So we're really focused on balance, and we ended up, after discussing at length different names for our study and a whole bunch of different acronyms, we decided to forget the acronyms and just call it the Balanced Opioid Initiative, because we think that balance is really the kind of the key term that is required to make progress in this area. And I guess, the takeaway is that we're seeing, and we hope that we'll continue to see, that we can strike the right balance when implementation scientists kind of held broker conversations between clinical guideline writers and primary care physicians. The people whose work is really affected by all these, policies that are and guidelines that are being put in place. But those stakeholders really need to be intimately engaged in the whole work of implementation at every step of the way. And that's what we tried to do. And so far, it seems to be working. And, we hope that we'll have positive results with this study, and hopefully learn a bit more about tailoring and optimization of implementation strategies along the way. But we're just getting into prime time as we speak. So I think that's it for my presentation. Next slide. Is there anything else? That's it. Well, I hope you enjoyed that. Please take a look at the readings. I will look forward to seeing all of you virtually. I wish I could, as I know we all wish we could be there in St. Louis. But I'll look forward to your questions when we talk on September 25th. So see you soon. Thank you.